How to Fill Out the K Section of the MDS by Doreen Rodo. I used to fill out 30 MDSs per week or 1,500 per year. So if you are an RDN, DTR, or dietary manager, it's a big part of the job. My goal today is to show you how to fill them out so you can complete them accurately. The OBRA regulations require nursing homes that are Medicare and Medicaid certified to conduct initial and periodic assessments for all of their residents. The Resident Assessment Instrument, or RAI process, is the basis for accurate assessments of each nursing home resident. The MDS, or Minimum Data Set, is part of that assessment process and is required by the Center for Medicare or Medicaid Services. How often MDSs are filled out may vary per individual, so don't worry about figuring out dates or the timetables because there is an MDS nurse who is responsible for telling the team the exact dates. Nutrition professionals generally fill out Section K. We answer conditions that affect nutrition, such as swallowing difficulties, height, weight loss or weight gain, and nutrition approaches. The Assessment Reference Date, or ARD. 7 days prior to the ARD is the observation period. It's during this time that we assess for swallowing issues, weight changes, and nutrition interventions. If any of these triggers occur within the observation period, then we would code for them. However, if a resident was having a swallowing issue and a puree diet was given, solving the problem, then we would not code for swallowing difficulties unless the swallowing issue was unresolved during the 7-day look-back period. When coding the MDS, we need to look at the most recent weight in the 7-day look-back period. For example, if the assessment reference date was May 23rd, we will take the weight closest to May 22nd, which might be the monthly weight for May on the 5th, or perhaps the weekly weight on the 20th or 21st. We also look at their diet and whether they were on a tube feeding in the 7-day look-back period. If they were on IVs on May 20th, then we would code for them. But if they were on them on May 5th, we would not code for them. Signing the MDS. We want to do this after the ARD date. If the ARD date is May 23rd, then we can sign the MDS anytime on or after May 24th. We want to avoid signing it too late. Closing date is usually within 1 week. Here's the first part of Section K. The intent is to assess the resident's ability to maintain adequate nutrition and hydration. The questions are loss of liquids or solids from the mouth when eating or drinking, holding food in the mouth, cheeks, or residual food in the mouth after meals, coughing or choking during meals or when swallowing medications, complaints of difficulty or pain with swallowing, or none of the above. Loss of swallowing ability can cause functional decline as well as choking or aspiration. The goal is to provide the safest texture. Ways to assess swallowing during the 7-day look-back period. Ask the resident, observe the resident, interview staff or significant others, and review the medical record. In 2019, CMS issued a final rule that changes the payment system to a patient-driven payment model. It is designed to give financial incentive to those who treat the individual needs of the patient. This is instead of focusing on the volume of services a resident receives. What does this mean for RDNs, DTRs, and CDMs? Make sure that you are accurately answering Section K0100, swallowing issues. Collaborate with the speech-language pathologist, staff, the resident, and family to ensure that these questions are answered correctly. The facility will get more reimbursement if the speech-language pathologist is involved with treating the resident. How to determine if there was a weight loss on a new admission. You can check the admission paperwork or ask the resident or family if there was a significant weight loss in 30 or 180 days. K0300. The question is, was there a loss of 5% in 30 days or 10% in 180 days? And was it a physician-prescribed weight loss? Snapshots between MDS periods are not captured on the MDS. This means that if there's a weight loss 60 days ago, we do not have to reflect it on the current MDS. However, if the weight loss was 180 days ago and it was significant and unplanned, we would still code 2 that it was an unplanned weight loss on the MDS. If there was someone on a reducing diet or a diuretic that had a significant weight loss that is documented within 30 or 180 days, then we would code 1, yes, on a physician-prescribed weight loss regimen. A thorough nutrition assessment should occur with any significant weight loss in order to determine if it was planned or unplanned. If K0300 is yes, then there should be supporting documentation in the chart and on the care plan. We do assess weight loss over 90 days when looking at weight change or when doing annuals and quarterly reviews, but it is not a criteria utilized when coding the MDS. So if there was a 7.5% weight loss in 90 days, but no significant loss times 30 or 180 days, you would not code for it on the MDS. Sample resident number 1. Initial weight was 200 pounds. They were placed on a reducing diet by the MD with an RD note and a resident care plan that states that weight loss is desired. 180 days later, they were 170 pounds, and this was a 30-pound loss, or 15% in 180 days. Pause the show to consider your answer. If you answered 1, MD-induced weight loss, you are correct. Sample resident number 2. They had an initial weight of 150 pounds, and the resident goes to dialysis with notes stating large fluid losses. The RD and the resident care plan state that weight loss changes were likely related to dialysis and intakes are good. 180 days later, the weight was 135. This was a 10% loss. Pause the show to consider your answer. If you answered 1, MD-induced weight loss, then you are correct. Sample resident number 3. The initial weight was 190 pounds, and in the RD notes it stated that resident needed more assist with eating. 30 days later, the person was 179 pounds. It was a 5% weight loss in 30 days. There was no fluid or medication-induced losses. There was no therapeutic diet. Pause the show to consider your answer. If you answered 2, not a physician-induced weight loss program, then you are correct. When assessing weight gain, compare the weight closest to the 7-day look-back period with weight 30 and 180 days ago, only these 2 snapshot periods. When evaluating weight gain, check for changes in calorie needs, medications, intake, and fluid volume. Keep in mind that some medications such as diuretics and prednisone can affect weight. K0510 nutrition approaches. They are parental or IV feeding, feeding tube, mechanically altered diet, therapeutic diet, or none of the above. If a person is on a regular diet, then you would select Z, none of the above. The use of IVs to prevent dehydration should be clinically indicated and have supporting documentation. This would be labs, MD, nursing, and RD notes. Do not code IV medications here or IVs given solely as flushes. Here are some helpful hints for coding enteral feeds. You can code also as a therapeutic diet if the enteral formula is altered to manage a medical condition such as diabetes. Do not put IVs for chemotherapy or dialysis here. We do not code them as a mechanically altered diet. In addition, if a supplement is given for protein-calorie malnutrition, then it can be coded as a therapeutic diet. How should this be coded? A resident has a UTI with dehydration and a fever. Inadequate fluid intake is documented. I and O show lower intake than output. She has a hydration plan to ensure adequate hydration. She receives 100 cc's of normal saline via IV. Pause the show to consider your answer. Parental tube would be checked because there's documentation that the 100 cc's is needed to maintain hydration status. How would this be coded? A resident has a UTI with no dehydration or fever. They have adequate fluid intake, and this is documented. There is a hydration plan to ensure adequate hydration, and they receive 100 cc's of normal saline via IV. Pause the show to consider your answer. Parental nutrition would not be checked because there is no documentation that supports the need for 100 cc's to maintain hydration status. Keep in mind that tube feedings and IVs can decrease a person's dignity and lessen their pleasure from eating. This could cause potential issues for diminished meal intake and possibly weight loss. Calories via artificial methods should be reviewed periodically, and we should have the speech-language pathologist assess the resident to see if they can take PO foods. K0710. Calculate calories through the parental or tube feeding routes. If there was a minimal intake by mouth, such as sips, then code 3, 51% or more. If PO intake is more substantial, the dietitian should calculate the amount. For example, if oral calories were 2,450 per week, tube feed calories were 15,000 per week, and total calories were 17,450 per week, the percent calories by tube feeding would be 85.9%, so we would code that as 3, 51% or more. Calculate weekly total fluid through parental or tube feeding routes. We divide by 7 even if there was a day without IV or tube feeding. For example, if the IV fluid was 6,300 cc's for 1 week, we divide that by 7 and get 900 cc's per day. So we would code 2, 501 cc's or greater per day. After the MDS is completed by the interdisciplinary team, the data is put together into areas of concern. This is called the Care Area Trigger, or CAT. It is an indicator of an issue or condition that affects the resident. Section K, Nutrition, is a Care Area Trigger. If a question answered on the MDS matches one of the CATs, then further investigation is warranted. This is the critical link between the MDS and care planning decisions. However, just because a CAT is triggered, this does not mean that we necessarily have to initiate a resident care plan. Care Area Assessment, or CAW, CAA. This is the summary on MDS findings or the triggered conditions on the MDS. This is where we can provide the information for care plan development. Additional questions are answered when filling out the CAW. However, we do not need to fill these out if the documentation in the chart is adequate. Not every person will trigger for a CAW, but they can still have a resident care plan. Documentation for the CAW must be in the medical record. There is no specific documentation format. Care Area Assessment is a summary near the end where the location of the nutrition information is noted. You state whether you are proceeding with a resident care plan and why. An example would be proceeding with a resident care plan related to weight loss and need for a mechanically altered diet, RD to follow PRN. Thanks for taking the time to listen to the presentation today. For more information about nutrition in long-term care or long-term care in the state survey, please check out my videos on Vimeo. The link is on the screen. Thank you.